at ASCO 2016, you're going to present data looking at 3 and 4 year survival from some of the early Nivolumab trials. Can you summarize what you think that data will have in terms of the impact of the conversation with the patient when you see a third of patients possibly benefiting from a checkpoint inhibitor out 3 and 4 years?
Yeah, I mean, you don't want to make too much out of, non-randomized data, but in those 2 trials, we have over 4 years of follow-up minimum on both studies now. And as you mentioned, a third of patients on both studies, over 200 patients, are alive at 4 years. On the phase 1, where we have 5 years of follow-up, a third of patients are alive at 5 years. I mean, that's a pretty remarkable number when we consider back 5 or 10 years ago, the 5-year survival of all patients with kidney cancer was around 5 or 10%. We're now seeing that with these salvage agents. So hopefully that survival benefit will be reflected again in the phase 3 trial as well. Other things we saw from that study were that patients benefited regardless of sort of risk group. So we saw long-term survival in good, intermediate, and poor risk. We've had a lot of conversations about, what the Sloan-Kettering criteria mean, but we saw benefits in all those groups, regardless of performance status. So if you had slightly reduced performance status, there were still some long-term survivors, and regardless of response, meaning half of our patients who survived 4 years on the phase 2 had either stable disease or progression of disease, which was Dan's point earlier, and lived 4 years. So, I mean, this sort of turns a lot of things we thought on its head. And the way I want to look at it is like, this is a good story. It makes it more difficult to talk to patients, but not in a bad way. It's much more difficult to tell a patient, we don't have much for you. Here we can, come up with our own spiel about how we're, our own pathway with individual patients, but we'll be talking about good options as opposed to no options.
Dan, you had some thoughts?
Yeah, I just wanted to correct David on a couple of things because he corrected me on a couple of things.
I politely corrected you.
Look, I don't mean to say we don't treat in the third line or we can't do clinical trials in the third line. We absolutely can, right. And they're definitely this subgroup that do well,
right.
With these patients. And they're probably a lot of the patients on your phase 1s and phase 2s
right.
are these patients that
Absolutely.
have gone through multiple lines
right.
and are just sort of destined. So teasing out sort of what's a treatment effect and what is a natural history selection effect is challenging, right? And so we need randomized data at the end of the day for that. The other thing I would just say, in your randomized data, in both Meteor as well as in CheckMate-025, if you look at the patients in the forest plots who have had 2 TKIs, those lines are much closer to no benefit.
Right.
So I'm not saying there's no benefit, but there's probably diminished benefit when you get further and further out. With any agent at the end of the day. It's just the disease gets stronger. And at some point, that's going to diminish. So it's remarkable to me that your phase 1 and phase 2 data have this tail.
Right.
How much of it is selection and how much of it is treatment effect? It's got to be both. I think it's a combination of both.
Right, and it's a sequence of drugs that followed.
Right.
And there may be a secret sauce of sequence that you have.
Although I will say, again, for those of us that are a few years older than Dan, not very different than the conversation that existed 30 years ago when we talked about a tail of the curve to IL-2.
Right.
Those were not randomized trials. And I remember the conversation as it was yesterday, which was, well, how do you know the tail is just not the natural history of the disease?
Right.
And we now understand that that's not the natural history of the disease.
Well,
the natural history is people go on to die, and they don't live 10, 20, and 30 years later, but you have to start at some place, and that's the key.